Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts. Hosted by cardiologist and top medical researcher, Dr. Michael Koren.
Hello, I'm Dr. Michael Koren, the executive editor of MedEvidence. And I'm really looking forward to this session. I have Dr. Judith Abbey here with me. And Dr. Abbey is a medical entrepreneur in our community here in Florida. And I'm really fascinated to know about your journey, how you got there, and talk about why you chose a bit of an unconventional way to serve the public. Tell us about your business, and importantly, tell us about how we use evidence-based medicine and science to make things better for patients in our community.
Thank you, Dr. Koren. It's an honor to be here with you. And they may not see, but we have additional people in the studio here with us who are making this episode wonderful. So just want to give a shout out to them. A little bit about me.
Don't flatter them too much because they may ask for a pay raise, which we really can't afford at this point. But I appreciate you reaching out to the
listeners may actually help.
Okay, well, there we go.
All right. But I'm originally from Ghana, so born and raised in West Africa, Ghana, moved to the United States in December 2011. So I have been here a while. Now, originally, when I moved here, I was under the impression of continuing med school. So back home in Ghana, I was enrolled in medical school, and that was the vision. I'd always wanted to be a physician. And I think culturally, part of it being that you become a doctor, and I think this is common across certain cultures.
Sure.
So you're either a doctor or you're a lawyer or an accountant. And I think it's because knowing that those professions, you end up doing well, you can take care of yourself and your family. But for me, it felt more like it was a calling for me. And so during my whole education, my plan was I was going to become a physician at that, and that was going to be the way for me to be a conduit for healing and for health, for people. I wanted to help people, make them feel better.
Yeah.
And so when I was in first year of med school back home in Ghana, I was told I was moving to the United States. I was like, okay.
How'd that happen?
My oldest brother was here with his wife. And I can't say for sure what their plan was, only maybe, they wanted me to have a better life and a better education.
I see.
Of course, it's
more opportunities
in
the U.S. versus Ghana.
In the U.S. than Ghana. And of course, the United States, it's a great country, and we can see many people often want to travel here for better opportunities.
Sure.
And so when I moved here, I was under the impression that, okay, because this is the trajectory I'm on, that's what I was going to continue on. I was informed I was doing nursing. I was like, okay. But I did not understand what that meant. I think for my brother and his family, it came from a place of, okay, nursing is the route where most people do nursing, and the career opportunities for nursing is just unending.
Right.
And I did come to understand later that there is a financial component to it when you look at what the nursing training model is compared to what the medical model is. Vast difference.
Yes.
And so I remember distinctly my brother saying to me, you can go.
What does your brother do, by the way?
He is a phenomenal guy. He currently works at ViStar. He is the SVP for Enterprise Risk Management.
Oh, very nice.
He is super smart.
So he's in the banking industry for
banking
everybody.
industry. Banking industry.
And your parents, what were they professionals or?
Mom was a assistant principal to a high school in Ghana, one of the most prestigious high school. She voluntarily retired.
They have a great private educational system in Ghana.
They do.
I know. Yeah,
they really do.
And Dad was?
Dad is into social development, social advocacy. He's gone working with the United Nations. He's worked with the African Union. Lots of international development organizations. So
very nice.
That was Dad's background.
Okay. Do they still live in Ghana?
They're here.
Okay.
They're here. We are
the whole family moved,
majority of us.
Okay.
So still have one brother back home with his wife. We were saying earlier that, one part of the family is missing and we always miss him, but it's a big family.
Sure. Okay.
It's a big family.
Sorry to interrupt. Go ahead. Yeah.
So
about your journey.
Nursing school, that was the decision, not doing medicine, you're going to nursing school. I'm like, okay, didn't question it. In hindsight, I know that was God's leading and that was God's doing. But I went to University of West Florida for my nursing degree, so my bachelor's in nursing. Graduated magna cum laude and won a couple of awards while I was there. And from there, I started working at a local community hospital. And that was Santa Rosa Medical Center. So started on med-surg, getting used to all the different patient populations. And really that's where my experience started from. So while I was at Santa Rosa Medical Center, just trying to figure out, where next do I go? What does the future look like for Judith? And so I enrolled at University of South Alabama. And the reason I went to that particular school was they offered a dual family and emergency medicine track, which I thought that was wonderful because once I had started in med-surg, I had jumped around to ICU, I had done PACU, I had done all sorts of things. Ended up in the emergency room, which I thought I would never be in the ER because ER is just crazy.
Sure.
But loved emergency medicine. And so I thought my trajectory was going to be an ER nurse practitioner. And this program was just perfect for that. Because if I end up not liking emergency medicine for some reason, I could always fall back and do family practice. So I went to South Alabama and graduated with my NP. That's where I pursued my doctorate also.
So nurse practitioner degree?
Yes, sir. Nurse practitioner degree. And so the doctoral part of it really was translating evidence into practice. So really that's what brought me to where I am currently. So I was working in Orlando at the height of COVID in the emergency room. And there was a lot of anxiety going into work because we got to really see what the frailties of our healthcare system is.
Absolutely.
And oftentimes patients don't realize how tragic or how difficult it is as medical providers, what we go through having to navigate this healthcare system. And so these are all things that contribute to healthcare practitioners always talking about burnout.
Right.
And I certainly felt burnt out, that anxiety. I had never felt anxiety or known what anxiety felt like, but I was at a point where I'm like, Lord, I don't know what anxiety is. And really, this was literally my conversation with God that I don't know what anxiety feels like, but I'm pretty sure that's what I'm feeling right now. And if you do not send me in a different direction, I don't know what's going to become of my career. Because at that point, I didn't feel like I was going into work and giving my best self to my patients. And we go into this field wanting to make a difference and wanting to make them feel better and being there for them at their worst. And especially as a nurse, the core of what we do is to be patient-centered and to be there for them. And we're not only focusing on you, the patient, we're focusing on your family as well.
Right.
And Judith was going to work, and Judith never felt like she was given her best self to the reason why she went into healthcare. And so that was my prayer to God to send me a different direction. And I chanced into this field, I think by accident. I think in God's grand scheme, it was not an accident. For now, the trajectory of what I do, it's very personable, not traditional in the sense that I'm not in a physical environment, but I get to be right where my patient is.
Sure.
So
explain your business a little bit for people. So it's On the Go
On the Go
Drip.
Drip.
So tell us how you came up with that name, number one. And number two, tell us how your business model works.
Okay. So number one, On the Go Drip came about from my mom. My mom
Really?
said, I was going through a phase trying to figure out what to call this business.
Right.
And we're throwing all kinds of names
So
around.
you committed to not work for an institution, not work in ER. You want to do something for your own.
Wanted to do something for my own.
Even though your parents weren't entrepreneurs necessarily, but maybe your brother had a little influence to say, hey, let's start a business.
I feel like it came from when I was working with this other company doing the same thing. And excuse me, I realized that every time I would go into a patient's home, they appreciated that I was there.
Right.
I actually felt like I was doing something.
Right.
Like I felt like I was making them feel better.
Absolutely.
So in comparison with what my traditional ER setting was, where you hear all these bells and sirens going off, the radio constantly going off because rescue is bringing in a patient, or you're back in the room with a Baker Act patient and there's 6 security guards in there trying to hold this one patient down, and you cannot. We've given him everything we could possibly can. He is throwing poop on the walls.
Right.
Very different setting. I had instances where a patient literally like would throw their cup of water at me because it took me a long time to bring them water, not knowing that in trauma room 37, we just had to resuscitate a patient. And so it was very different going into these people's homes, and they appreciated that I was there, and I actually felt like I was healing, like I was doing something. And that feeling, or that fulfillment for which I went into healthcare, it was there again.
So by starting your own business, you had a sense that you were making a difference in people's lives.
That's correct.
And did not get that sense when you were in the institutional setting.
That is correct.
So that was a big motivator for you.
That was a big motivator.
And so starting a business is hard. There's a lot of things you have to do. Who helped you with that?
God. And also the right people, really, because
I can use God's help, I think, for my business.
I highly recommend it. I highly recommend it.
Okay, well, I know God can do accounting and legal work and everything else.
He works through people, and he sends the right people. And I think that has been what's been driving me forward, because I can speak specifically to my training. There was not a single iota of entrepreneurship or business in there. I knew how to take care of a person.
You were not driven at all by the financial side.
Nothing
just
like
on
that.
The personal side and the connectivity with the patients, and you figured out the financial side.
We're learning on the fly.
Got it.
But God has sent the right people to me every single time to make it work.
Because the wrong people can create huge problems.
Oh my gosh, lots of problems.
Yeah.
Lots of problems.
Okay, so tell us a little bit about your business model, and then we'll get into some of the type of patients that you help.
Okay.
So I want to get you to become part of my medical team. So how do I go about that? How do I pay you? How does this all work?
So this is strictly cash pay. Insurance does not cover this yet.
Okay.
And how this works is I will pick a case of food poisoning. So if there's somebody who ate something bad and they're having food poisoning, or they got the stomach flu, in certain instances, you go to the emergency room or you go to urgent care because it's coming out from up here and down there. You're both sides, and you're absolutely feeling miserable.
Norovirus.
Terrible. We've been seeing lots of those cases the past couple of weeks.
Yeah, and we're trying to prevent that with vaccine studies, by the way, here.
We are, and that we want to encourage people to definitely pursue that route.
Yeah.
And so they go to the emergency room for these conditions. One, there's that whole wait time. And this is something I saw a lot practicing in the emergency room, because already we have like 50 people in the waiting room. Everybody feels that they're there for an emergency.
Sure.
But for somebody who is puking and having diarrhea at the same time, they do not want to be there.
Right.
And so...
not to mention the fact the triage nurse calls you and says, Mr. Jones, can you come out? And Mr. Jones is in the bathroom. So misses his turn.
Exactly. And Mr. Jones comes out not too happy at all. Right. And so what we do for Mr. Jones is, Mr. Jones, instead of you going to the emergency room, you reach out to us. You stay home because it's easier for you to go to the bathroom while you're home. Right? And you're right in your own environment. It's comfortable for you. We will come to you. We'll take all that hassle out. You're going to get the same medical care you would at the ER or the urgent care. And this is in the comfort of your home. So really that is what the model is. It's very patient-centric.
Yeah. So, and again, what are they going to do for you in the emergency room? There's no magic cure for a norovirus. You're going to get hydrated, get your electrolytes, and
treat your symptoms.
And it's going to run its course over a few days.
So same thing. So we're going to hydrate you, and we're going to give you some Pepcid if it's necessary. Sometimes we do an antiemetic, depending on how bad it is. We call in prescriptions for you.
Beautiful.
So it is a whole medical process.
And how much would that cost somebody? So that's always important for people, is the economics of it.
So on average, it's going to cost you about $300. If we're going to to do additions to it, then the prices could fluctuate.
Right, and a lot of insurance companies have copays of $250 or $300 or more when you go to the emergency room.
Right, right. So if you would consider that time of you having to get in your car and the drive time, go sit in the waiting room, wait for hours on end before you're pulled back, and then you're there forever before the physician comes to see you, and so.
And is it just you at this point, or do you have people that help you?
We're a small team, so we have a small team of 3 plus me. So
Nice.
we're growing.
Okay. And how do you get the word out other than this podcast?
Word of mouth has been very essential. Google reviews have been phenomenal too. We're also doing some ads here and there on social media, also Google.
So you mentioned acute diarrheal illnesses. How about other things that you do for people? What other services do you provide?
So I often like to categorize this into, we have the sick care. So we know with a food poisoning or somebody who's really hangover, they're having all kinds of symptoms from it. We see patients for migraine.
Hangover
treatment.
cures. I think that might be a big business.
It is. The hangover part is what has popularized what IV therapy is over the last couple of years. Because people go to all these parties and they get drunk and they get hungover and oh, I need a banana bag, so that has definitely popularized what IV therapy is. And so
the other cure for hangovers was to give more alcohol. I don't know if you do that.
Is that
part of your
No.
Is that part of your protocol?
No.
Okay.
Unfortunately not.
Okay, well, I don't think that's evidence-based.
It's not.
Okay.
And so the sick component part of it, we deal with those minor acute things, and there's the other part for wellness where we have individuals who they're not sick, you would say. However, they understand the importance of nutrients or nutrition in their lifestyle. So we have some patients we work with who have chronic conditions, especially those who have gastrointestinal things, either malabsorption, Crohn's, where they're not necessarily getting all the nutrients they need. This becomes a way for them to supplement that.
Right.
So a big part of it is doing lab work to identify what the gap is, what the ranges are, and then that helps us to tailor a treatment plan for them.
Right.
So those are the 2 categories.
Gotcha.
And I always want to educate that there is a maintenance therapy and then there's a replacement therapy. So in instances where we're doing maintenance therapy, it's okay. We know there are maybe somewhat of abnormalities or we're not within range where our body needs to be. And so we do maintenance therapy to get our body maintenance, really what it means.
Okay.
If we're doing replacement therapy, I'll illustrate this with a patient that I worked with. So she had a complete thyroidectomy. Her thyroid's gone. It's been months trying to regulate her calcium levels, and she's tried everything. Her team had her on everything. She reached out to us. We rechecked those levels. Of course, she was hypocalcemic. So we came up with a plan, did a couple treatments, specifically replacing her calcium.
You give intravenous calcium?
Intravenous calcium.
Okay.
And then after that, we recheck labs. Boom, she's back within
Beautiful.
range.
Yeah.
So then that becomes replacement therapy.
Right.
So for some people, after we've done replacement therapy, then we cycle back to maintenance therapy. But then there's always that lab work component trying to make it evidence-based and direct care.
Right. So I think those are important points. And I think it's fair to say that not everybody in this quote, less regulated space of bringing healthcare to patients' homes is as evidence-based as you're describing. So you and I were just talking before we got started about vitamin C therapy, which is a little bit controversial. So we know, for example, that if you are vitamin C deficient, that vitamin C replacement can help, just like we learned about scurvy, for example. But giving very high doses of vitamin C has never really been proven to do a lot of good, although some people will advocate that without evidence. And we'll post what's called a forest plot of a lot of studies that we're doing specifically to see if high doses of vitamin C prevent cold symptoms. And the truth is that they really don't, even though some people will take the data and try to say, oh, well, that one study it was trending in the right direction. And this gets into some of the technical elements of analyzing the evidence, which we'll show in the show notes. But I love the fact that you're very evidence-based and you're helping people resolve their symptoms and you're lab-directed. And these are very important distinguishing factors to show that you're doing a really nice job with evidence.
Absolutely. You hit the nail right on the head. And usually when it comes to vitamin therapy, you hear that, oh, this is expensive P, or you hear all these kinds of labels for it. And often in our medical world, or when it comes to research, sometimes it's hard to quantify or really lend much credibility to anecdotal evidence. So we hear all these patient stories, success stories, but it can be quite hard to really say, I'm going to do a randomized control study specifically for vitamins. Now, I have seen some studies where they are talking about high-dose IV vitamin C for cancer care, not as their primary. And we always want patients to understand that you should be working with your medical team and going with what they recommend and making sure that the evidence supports that.
Or doing it in a clinical trial.
Or during a clinical trial.
In a clinical trial where you're systematically setting up an experiment where you'll learn the truth.
Right.
Yeah.
Right. And so you did talk about colds and vitamin C. And yes, taking vitamin C during a cold is not going to cure it. We do know that vitamin C may make your symptoms lower or reduce how long you have the cold for, or even with zinc.
And in fairness, that's debatable.
That's debatable.
And we can show the actual evidence.
Right.
So again, with things like that, there's no harm in taking vitamin C.
No.
Okay. But what concerns me is when people try to oversell it. And the fact is that the studies that have looked at it have not been consistent, and meta-analyses have shown that it's probably a wash, quite frankly. And a lot of other stuff looking at vitamins in general show that using vitamins when you're deficient is great.
It's helpful.
Right.
It's helpful.
But using vitamins when you're not deficient probably doesn't do a whole lot.
Right.
So again, I think that's a general sense, and other things should be done, in my opinion, in clinical trial setting.
Right, right. And also, it's interesting to know that the majority of what the American diet is, most people are deficient in certain things and they have no idea. So magnesium is a very common one that most people tend to be deficient in, not knowing that they're deficient in magnesium. So I think that's key for us doing that blood work to know where do you fall at, and then that really helps guide care.
Yeah, I love that. I'm a cardiologist, and you're absolutely right. A lot of people are on diuretics that waste magnesium, and a lot of people don't know that magnesium is hard for a lot of people to absorb.
Right.
Unless you test it, you don't know if people are deficient. And for magnesium in particular, you have the blood test, which is not the perfect way of knowing if you're full body deficient. And so you have to do a cellular test to determine that, and sometimes that's expensive, and we don't do that, except in rare circumstances. So sometimes you have to have a little index of suspicion. And again, we know that people that are deficient in magnesium will have more palpitations, for example.
Right.
They may have other complications that are very, very subtle that you don't really get to until you replace the magnesium. And what's interesting is that if your kidneys work, you can't really overdose of magnesium. So you always have to look at the safety elements of it.
That's very true, because when we work with individuals who have comorbidities and they have a whole list of, other conditions they're dealing with, then we're very particular, wanting to know what their kidney function is. And that lab work really, really becomes important, because yes, it could be benign for a healthy individual who just needs to replace their magnesium. But then for somebody who's in kidney failure or they have other things going on, it's very critical to know how you're treating them.
That's right. So any solution that works for one person may not work for somebody else.
Absolutely.
You have to individualize it.
100%. And I think that's one thing we try to really push, is going back to, oftentimes people see what IV therapy is and they're like, oh, I can just pick this, or I can pick that, or I can pick that. No, it really should be personalized to you. And there has to be a conversation with you and your provider, or even before the nurse or the paramedic, whoever actually does that infusion for you, you as the patient need to have a conversation with either a nurse practitioner, a physician assistant, or a physician in some sort, so they know, if they get a thorough history of really who Mr. Jones is. And then that should guide what the treatment is going to look like, because at the end of the day, it is still a medical process.
Right. It's interesting. I happen to have an interest in magnesium. It's one of the first investigator-initiated studies that I did when I first got into practice over 30 years ago. And magnesium is a particularly fascinating area for you, because we actually use high doses of IV magnesium to treat arrhythmias.
Yes.
So in an arrhythmia called torsades, we use very high doses of IV magnesium.
Right.
Obviously, you shouldn't be dealing with torsades
Right.
in somebody's home, which is a life-threatening problem.
No.
But the concept of getting the magnesium level up quickly and having an effect on the heart is well known. But you have to, again, individualize it. So
Yes.
there may be some cases where taking the pills is going to be okay. But the truth is you can get your levels back to normal much quicker by using IV magnesium compared with pills, which some people just can't absorb very well.
No. And we always want to advocate for food. Food should always be the go-to where we're getting all these nutrients from. But for whatever reason, sometimes food does not meet those requirements. So this is a good way for you to supplement that. Right. But then going back to the magnesium conversation, you do a basic Google search and you find different kinds of magnesium for different things. So sometimes patients find it hard to figure out, okay, what is the right magnesium for me?
Right.
And so people understanding that, yes, magnesium, but then that second part of the magnesium is really going to tell you what that magnesium is going to do for you and how beneficial it is going to be for you. But we can circle back to that conversation.
And sometimes it's a little bit of trial and error. Some people absorb one magnesium salt better than another. They do better with magnesium oxide versus chloride versus something else.
Right.
Yeah. All right. Well, that's really helpful information. So what other patient types have you been able to help, just for the audience to understand where they might want to call your service?
Right. There is a particular direction that I feel like the functional space, or buzzword anti-aging longevity, is going towards. And there's this molecule called NAD, or nicotinamide adenine dinucleotide.
Antioxidant, yep.
And so NAD is a coenzyme or a cofactor, and NAD is found in every cell in our body. And so we are beginning to have some sort of evidence that is given as a causal link between low levels of NAD and certain conditions or certain diseases. And for which reason? It's because NAD is implicated in all of these metabolic processes. The theory is, as our NAD levels decrease, if we're able to replenish that NAD, maybe we could reverse some of these conditions. Maybe we could live a bit healthier. Maybe we could live a bit longer.
Right.
And so what we're using NAD therapy for, and again, NAD is mostly concentrated in those mitochondrial cells or I should say organ systems where there's a high concentration of mitochondrial tissue. So your heart, your brain, reproductive tissue. And so NAD tends to be quite pronounced, or for the patients we work with, NAD tends to be very beneficial for them in those regard. Over time, I say to people all the time, you can't just take one thing, you can do one time, and that's not how, research, you try for a while so we can collect some information and see what the improvement is.
Right.
Has anything changed? Has it not changed?
Yeah, and this, in fairness, is a little bit more controversial than some of the other things you brought up.
Right.
So the whole antioxidant hypothesis is something that has been out there for quite a number of years. I actually worked in a lab when I was in college that was working on some of these things. And unfortunately, for whatever reasons, supplements haven't had the effects that we had hoped. That doesn't mean that the future won't be different. And it doesn't mean that there isn't a glimmer of truth in the hypothesis, but we don't really know exactly how to deal with it at this moment.
Right.
So one of my first scientific publication was showing the antioxidant effects of free radicals that were generated when you use the chemotherapeutic drug called adriamycin. And the simplest way of getting rid of the free radicals is just introducing oxygen to the system. So no one really thinks that is going to solve the problem, but it does change the free radicals.
Right.
So it gets very complicated in terms of this whole concept of what to do with these free electrons that can cause tissue damage and how do you manage that, which is really what the whole NAD hypothesis is looking at.
Right.
Are you familiar with the work of Dr. McCord from Duke?
No, I'm not.
Yeah, he was one of the original pioneers of this. I don't know if he's still around. I haven't checked his work recently. But
how long ago was that?
This is when I was in college.
Oh, boy. I probably wasn't born
it's more,
then.
right, more fingers and toes than I have to count that far back. But anyhow, it's some interesting stuff, but I would put that more in the unproven category, more hypothesis generating. Anyhow, so why don't you tell people how we get your service. How do you get in touch with you and your team?
Wonderful. So we have a wonderful website, On the Go Drip. I feel like On the Go is it just rolls right off your tongue.
I like it.
So you go to www.onthegodrip. That was a mouthful. onthegodrip.com.
One word?
All one word, yes.
Okay.
All
On the
one
Go
word
Drip.
together. Yes.
Okay.
onthegodrip.com. And we have all the information you need
So you
on
can
there.
just work online and then
You can work online. You can give us a phone call. You can send us a text message, whatever is
Why don't you tell everybody
convenient
what
for
your phone
you.
number is?
904-544-5010.
Excellent.
That's our phone number.
And what's your typical response time if somebody calls?
About 30 minutes.
Wow. Okay. Well, that's better than
In
you
30
are.
minutes. Way better. Between 30 minutes to 1 hour, we would have somebody at your location.
Wow,
Yeah.
that's amazing.
Yeah.
Well, thank you for now that I know that, I might send some patients your way.
Absolutely. It would be an honor. It would
be
be an
great.
honor.
Any last words for the MedEvidence audience?
I have a question for you.
Sure.
Because sitting right across from you, there is this book behind you that's just like staring right at me.
Yes.
And I just want to know what the story behind that book is.
Let me see which book you're talking about.
It's very prominent.
This one?
That one. Okay. That one.
Okay. Wow. This was not a setup, by the way.
No.
You just happened to ask about this book. So, when I was in medical school, I took courses at the Harvard School of Public Health. And Dr. Weinstein and Dr. Feinberg led this course on decision analysis. And this is a book that they wrote together with some other authors back in the 1980s when I went to medical school. Dr. Feinberg was my medical school advisor, who became the dean of the Harvard School of Public Health while I was there. And obviously, it was nice to have a mentor that became the dean, but he actually also became the head of the Institute of Medicine some years later.
Wow.
So he was one of my teachers and mentors and tremendous. I learned so much from him. Dr. Weinstein was the primary guy. He was a physician. He was a non-physician. He was the primary guy that ran the course, teaching about how to use quantitative analysis to make medical decisions. So my claim to fame is that I took their course, and it was probably the fourth year or so that they did the course. I did. I took the course, and this was the book from the course. And I was the first student to get a perfect score on the final exam, including the extra credit question. So that's my biggest claim to fame. So thank you for bringing that up.
No way.
Yeah. And it was really me.
That is unbelievable.
But anyhow, it's a great book that helps you analyze how to make medical decisions. And my medical school thesis was about whether or not to neutralize the acid content of pregnant women before they deliver to prevent the acid aspiration syndrome. And that was my first major medical presentation on that.
What were your findings on that? That sounds...
It was, well, I have my thesis in my office if you want to read it.
I would love to read it.
It's only 150 pages of light reading. But and you're probably the first one to ask to read it.
I would love to.
Other than my mom, who read the introduction and like that didn't read any of the paper. But anyhow, we basically found that it was important to neutralize the acid content of pregnant women, and that if you had the ability to predict when the delivery was going to occur, you should use a histamine blocker like Tagamet or in those days, or Zantac more recently. And that was actually helpful to neutralize the pH of the stomach content. So, God forbid the pregnant woman vomits and aspirates, they're much less likely to get severe lung damage.
Oh.
So that was the finding.
Wow.
And we actually looked at how much it cost. So back then, Tagamet was a drug you had to pay for. It wasn't a cheap generic. That wasn't that much, but it wasn't a cheap generic. And does the system spend $1 million to protect a certain number of women? So we actually brought it down to the financial parts, which is why I'm always interested in business and how people in the medical field develop their business models.
Right. Wow. So if you could predict or you knew exactly when the mother was going to deliver, then you would give the histamine blocker how far out before delivery?
Typically, you would want to do it within a few hours. Say, 2 to 12 hours before.
Right. That is pretty cool.
So that's what we discovered. But thank you for the question.
Absolutely. It was just staring like it's placed differently from the rest of the books in in your collections. I was like, it must really mean something too. There's a story behind it.
Yeah, there is a story behind it. And again, it's the way we should be thinking about medicine in terms of quantitative decision analysis. That is definitely one of the points we make on MedEvidence. And people should find physicians or nurse practitioners or other medical providers that think in those terms.
Absolutely.
We think in terms of analytics. We think in terms of what's proven. And we're not just trying to make up stuff as we go along.
Right.
We're doing, we don't know everything. And sometimes we have to make decisions based on uncertainty. But for the things that we do know, we need to leverage those things. And it's an important part of what we do.
Wow.
So
That's phenomenal.
Thanks for asking the question.
Absolutely.
So, Judith, you've been a delight. Thank you for joining us on MedEvidence, and we'll have you back again.
Thank you.
And good luck on your business.
Thank you. Thank you very much.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.